There is a belief, and it is a reasonable one, honestly, that knee pain after age 60 is simply what happens. Cartilage wears down, joints stiffen, the body accumulates decades of use, and the knees, well, they bear the brunt of it. Most people accept this. Most clinicians at some point in the conversation nod and say something about degenerative changes, and that framing is not wrong exactly, but it may be deeply incomplete. Because what if, in a meaningful subset of older adults, the inflammation driving that knee pain, the swelling, the morning stiffness, the kind of ache that doesn't quite respond to rest the way it should, what if that inflammation is not originating in the knee at all? A study published on February 12, 2026, from the University of Birmingham has brought into sharper focus something that immunologists and periodontists have been circling around for over a decade. The connection between chronic gum disease, specifically advanced periodontitis and systemic autoimmune activation that targets joint tissue, and the mechanism is not vague, it is not hand-waving. It involves a specific bacterium, a specific biochemical process, and a specific failure of immune recognition. And yet, for millions of older adults currently managing chronic knee pain with anti-inflammatory medications, this connection has never once been mentioned to them. That is worth sitting with for a moment. Let's talk about what the mouth actually is, biologically speaking. Not socially, not cosmetically, biologically. The oral cavity is one of the most bacterially dense environments in the human body. That is not a problem in itself. The oral microbiome, when balanced, is protective. But when oral hygiene deteriorates, or when immune surveillance in the gums weakens, which happens naturally with age, certain pathogenic bacteria begin to dominate. And among those, one species has attracted extraordinary attention in immunological research over the past 15 years. Porphyromonas gingivalis. This is not a rare or exotic organism. It is remarkably common. It colonizes the subgingival space, the area just beneath the gum line, and it thrives in the anaerobic pockets that form as gum tissue pulls away from the teeth. That pulling away, that deepening of the pockets between gum and tooth is what defines periodontitis. And here is the thing that often surprises people. Periodontitis can be present for years without causing obvious pain. Gums may bleed during brushing. There may be mild redness, perhaps some recession, but it is rarely dramatic enough to prompt urgent action. And that is precisely what makes it dangerous. Because while the disease itself may feel minor, cosmetically annoying, perhaps the biological consequences are not minor at all. Bleeding gums are not just a sign of local irritation. They are, quite literally, an open doorway between one of the most bacteria-rich environments in the body and the bloodstream. Every time inflamed gum tissue is disturbed by chewing, brushing, even during sleep in some cases, bacteria enter circulation. And Porphyromonas gingivalis, in particular, does something once it enters the bloodstream that most oral bacteria do not do. It produces an enzyme called peptidylarginine deaminase. That is a mouthful, forgive the expression. The shorthand is PAD, and what PAD does is chemically modify proteins through a process called citrullination. Now, let me explain citrullination in plain terms, because this is the linchpin of the entire mechanism. Proteins in the body have a specific shape. That shape determines how the immune system recognizes them. The immune system is constantly scanning, constantly checking whether proteins belong to the body or are foreign. Citrullination changes the shape of normal, healthy proteins. It converts an amino acid called arginine into another called citrulline. The protein still exists. It is still in the body's own tissue, but its shape has been altered just enough that the immune system may no longer recognize it as self. Take a careful look at the diagram appearing on your screen now. What you are seeing is a simplified representation of a normal protein recognized by the immune system as belonging to the body, and beside it, the same protein after citrullination. Notice how the structural change, while subtle, is enough to trigger immune recognition failure. The immune system begins producing antibodies against these modified proteins. These are called anti-citrullonated protein antibodies, or ACPAs, and their presence is one of the most reliable markers for rheumatoid arthritis. This is not theoretical. This is measurable. This is in the blood work. The University of Birmingham study, published this year, advanced this understanding in a significant way. What the research team demonstrated, building on earlier work from institutions including the University of Helsinki, Johns Hopkins, and several collaborative European centers, was that in older adults with both chronic periodontitis and elevated ACPA levels, the bacterial load of Porphyromonas gingivalis in the oral cavity was strongly and consistently correlated with the severity of joint inflammation, not just presence, severity. The worse the gum disease, the more intense the immune response in the joints. And the joints most frequently affected, weight-bearing joints, knees in particular. This makes biological sense when you think about it. Knee joints in older adults are already under mechanical stress. The synovial membrane, the lining of the joint, is metabolically active and highly vascularized. It is, in a sense, vulnerable. When citrullinated proteins circulate through the blood and lodge in synovial tissue, and when the immune system has already been primed to attack those modified proteins, the knee becomes a site of autoimmune inflammation. Not wear and tear, not mechanical failure, immune-mediated destruction. And here is where clinical observation becomes particularly troubling. Many clinicians report that older adults presenting with chronic knee pain are evaluated primarily through a musculoskeletal lens. Imaging is ordered. Cartilage loss is identified. A diagnosis of osteoarthritis is made. Anti-inflammatory medications are prescribed, typically NSAIDs, sometimes corticosteroid injections, and for many patients, this provides temporary relief. The swelling decreases, the pain becomes manageable, but the underlying immune activation continues. The citrullinated proteins are still circulating, the gum disease is still present, and the immune system is still confused. Consider, hypothetically, a 68-year-old woman. She has had knee stiffness for 4 or 5 years, morning pain, difficulty with stairs. Her dentist mentioned some gum recession at her last cleaning, but nothing that seemed urgent. She takes ibuprofen most days, sometimes naproxen. Her stomach has been bothering her lately, but she attributes that to diet. No one, not her rheumatologist, not her primary care physician, not her dentist, has connected these two things. Because in practice, medicine is often compartmentalized in ways that the body is not. The body does not compartmentalize inflammation the way we often assume it does. That is a sentence worth repeating. Chronic inflammation rarely stays local. It migrates, it amplifies, it finds vulnerable targets. And in aging immune systems, where regulatory mechanisms are already less precise, a phenomenon sometimes called immunosenescence, the risk of misdirected immune responses increases. The immune system becomes, for lack of a better word, less discriminating, more reactive, more likely to mistake altered self-proteins for threats. This microscopic view illustrates how the bacteria enter circulation through inflamed gum tissue. Notice the disrupted epithelial barrier, the thin lining that normally separates oral bacteria from the bloodstream. In healthy gums, this barrier is intact. In periodontitis, it is compromised, and through those gaps, Porphyromonas gingivalis and its enzymatic products gain access to the systemic circulation. Now, let's talk about the medications, because this is a sensitive area and it deserves a balanced discussion. NSAIDs, ibuprofen, naproxen, and others in that class are not bad medications. They serve a real purpose. They reduce prostaglandin synthesis. They lower acute inflammation. They relieve pain. For short-term use in appropriate patients, they are valuable tools. But in older adults, taking them daily or near daily for months and years, which is extraordinarily common, the risk profile changes substantially. Gastrointestinal bleeding is a well-documented concern. The gastric lining, which is already thinner and more vulnerable in older adults, becomes increasingly susceptible to erosion. Kidney function, which naturally declines with age, can be further compromised by chronic NSAID use. Cardiovascular risk, particularly with certain NSAIDs, has been the subject of serious scrutiny for over 2 decades. These are not rare side effects. In geriatric medicine, they are frequent complications. And yet, the medications continue, because the pain continues, because the underlying driver in at least some of these patients has never been identified. This is not about blaming physicians. This is about the structure of medical education, the siloing of specialties, and the relatively recent emergence of oral systemic research as a serious field. 20 years ago, suggesting that gum disease could cause knee pain would have been met with skepticism in most medical circles. Even 10 years ago, it was considered fringe by many. The Birmingham study, and others like it, are changing that. But clinical practice evolves slowly. Guidelines lag behind research. And patients, understandably, rely on the framework their providers offer them. So what does this mean practically? What, if anything, can be done? This is where the conversation shifts from mechanism to action, and it is important to be measured here, responsible. Because the temptation, and it is a real temptation, especially in health communication, is to oversimplify, to say, fix your gums and your knees will heal. That would be irresponsible. The immune system is not a light switch. Autoimmune processes, once established, involve complex cascades of cellular memory, antibody production, and tissue remodeling that do not simply reverse when the initial trigger is removed. But, and this is a significant but, reducing the ongoing bacterial load, lowering the continuous supply of Porphyromonas gingivalis entering the bloodstream may reduce the rate of protein citrullination. It may lower the stimulus for ACPA production. It may, over time, decrease the systemic inflammatory burden that is feeding joint inflammation. Emerging research suggests this. Inflammatory markers, C, reactive protein, interleukin-6, tumor necrosis factor alpha, have been observed to decline in patients who receive comprehensive periodontal treatment, not dramatically, not overnight, but measurably. And in a condition like rheumatoid arthritis, where disease progression is driven by cumulative inflammatory damage, even modest reductions in immune activation can be clinically meaningful over months and years. So here is a practical framework. 3 steps, not revolutionary, not exotic, grounded in basic periodontal science and supported by the emerging oral systemic literature. Step 1, brushing with attention to the gum line. This sounds elementary. It is not. In practice, most people brush their teeth. Fewer people brush their gums. The objective is not just to clean the tooth surface, but to disrupt bacterial colonies at and just below the gum margin. A soft bristled brush, angled at roughly 45 degrees toward the gum line, with gentle circular motions. Electric toothbrushes with pressure sensors can be helpful here, particularly for older adults with reduced manual dexterity. The goal is consistency, twice daily, 2 minutes minimum, and specificity. Not scrubbing. Disrupting the biofilm where it forms. Step 2, daily interdental cleaning. Flossing, or the use of interdental brushes, or water flossers, the specific tool matters less than the habit. Because Porphyromonas gingivalis thrives in the spaces between teeth, in those subgingival pockets where a toothbrush simply cannot reach, many older adults have wider interdental spaces due to gum recession, and interdental brushes of the appropriate size may be more effective than traditional floss. The point is, mechanical disruption of the bacterial biofilm in those protected niches daily, without exception. This visual helps clarify why interdental cleaning is so critical. Notice the pocket depth between the tooth and the gum tissue. Bacteria colonize the deepest portions of these pockets beyond the reach of any toothbrush. Without interdental cleaning, those colonies remain undisturbed, growing, producing enzymes, and maintaining the inflammatory cycle that keeps the gum tissue bleeding and permeable. Step 3. Professional periodontal evaluation and, when indicated, treatment. This means a visit to a dentist or periodontist not just for a cleaning, but for a specific assessment of pocket depth, bleeding on probing, and bone loss. If periodontitis is present, scaling and root planing, sometimes called deep cleaning, may be recommended. In more advanced cases, surgical intervention or localized antimicrobial therapy might be considered. The important thing is that the disease is identified and managed, not just observed. Many older adults have not seen a dentist in years, sometimes decades. This is not always a matter of neglect. Dental care is expensive in the United States, and Medicare does not cover most dental services. That is a systemic failure, frankly, and one that has enormous downstream health consequences. But where access exists, periodontal evaluation should be considered a component of overall inflammatory risk management, not merely dental maintenance. Now let me be clear about what this framework does not promise. It does not promise that knee pain will disappear. It does not promise that rheumatoid arthritis will go into remission. It does not replace rheumatologic care, physical therapy, or appropriate pharmacologic management. Autoimmune disease is complex, multifactorial, influenced by genetics, by hormonal status, by environmental exposures far beyond the oral cavity. But what this framework does, and the Birmingham study supports this, is address one modifiable upstream trigger, one source of chronic immune provocation that, in many older adults, is entirely untreated. And in a body already burdened by age-related immune dysregulation, removing even one persistent inflammatory stimulus can shift the balance, not dramatically perhaps, but meaningfully. In autoimmune conditions, patterns emerge over time that consistently point toward cumulative burden. It is rarely one thing. It is the accumulation of insults, metabolic, infectious, inflammatory, that overwhelms regulatory capacity. The oral systemic connection is one thread in that web. But it may be, for some individuals, the thread that is most accessible, most correctable, and most overlooked. Long-term inflammatory research suggests that the distinction between local and systemic disease is increasingly artificial. The body is a continuous system. The mouth is not separate from the joints. The gums are not isolated from the immune system. Blood circulates, bacteria travel, proteins are modified, and the immune system responds to what it encounters wherever it encounters it. What appears unrelated anatomically may be biologically connected at the molecular level. That is one of the more humbling lessons of modern immunology. Notice here, in this final visual, how citrullonated proteins alter immune recognition in the synovial membrane. The antibodies that were generated in response to bacterially modified proteins, proteins altered by an enzyme from an oral pathogen, those same antibodies attack structurally similar proteins in joint cartilage. The immune system is not malfunctioning, exactly. It is doing what it was designed to do: identify and attack abnormal proteins. The tragedy is that the abnormality was introduced by a bacterium and the collateral damage falls on the patient's own tissue. That is the mechanism, that is the link, and it deserves far more attention than it currently receives in standard clinical practice. For those watching who are in their 60s, 70s, or beyond, who have been living with chronic knee pain, who take anti-inflammatory medications regularly, who have noticed bleeding gums or have been told they have gum disease, this is not a call to panic. It is a call to ask questions, to mention gum symptoms to a rheumatologist, to mention joint pain to a dentist, to begin bridging the gap that the medical system has, perhaps inadvertently, maintained between oral health and systemic health. Talk to your physician, talk to your dentist, and ask whether, in your specific situation, periodontal health might be relevant to your inflammatory profile. It may not be the answer, but it may be part of the answer, and that distinction matters enormously when the alternative is years of escalating medication with diminishing returns. Inflammation accumulates quietly over time. Addressing it requires looking in places that may not seem obvious. The mouth is one of those places. And for a generation of older adults whose joint pain has been managed but never fully explained, the oral systemic connection may offer something that has been missing from the conversation. Not a miracle, not a cure, but a deeper, more honest understanding of what the body is actually doing and why. If any of this resonated, if you are someone who experiences both gum issues and joint pain, consider leaving a comment below with your age and your experience, not for any commercial purpose. But because these patterns become visible when people share them, and visibility is the first step toward better clinical recognition. If you found this discussion valuable, a like or a subscription helps others find it. That is all. No urgency, no pressure. Just the hope that useful information reaches the people who need it. Thank you for your time and your attention. These are not simple topics, and the willingness to sit with complexity to resist the appeal of easy answers that is worth something. Take care of your gums. Ask better questions, and understand that the body, in its frustrating and beautiful way, is always more connected than we expect it to be.